Michael, thank you very much. It's indeed an honor and pleasure to be here. I remember only one thing from physical chemistry. I could not have even applied to Yale. I barely got into Berkeley eventually. But the one thing I remember from physical chemistry was that single enzyme curve, Vmax, that it goes like this, and then all of a sudden the enzyme takes off and then levels out again. And it's something that I've always used when I've hired people to try and get them at Vmax. And I think this is the program at Vmax, accelerating. It's indeed a great pleasure and honor to be here. I'm going to go over a couple of things here about prostate cancer, the spectrum of disease. A lot of this are my current thoughts on this. I couldn't on their CME put these conflicts in, but these are my conflicts. So I think the first disclosure is, I think prostate cancer is a spectrum of disease. I think that's really important. It's both over and undertreated. I'm going to show you that. Risk assessment needs to be precise and nuanced, not just three categories. I'm a very high volume surgeon, but I have one of the largest series of active surveillance in the world. I think outcomes of treatment should be well documented. I think for young people in the room, you want to document your outcomes because you learn from them and you change your behavior based on them. I've learned much. I have much to learn, and the data that I'm going to show you is largely my own. So the past, when I trained, we had screening was widely done and repeatedly done. So people got PSAs repeatedly at all ages. Biopsies was done in all patients. So elevated PSA, you went to biopsy. Digital rectal examination was, I think, important early on. I think it's less important now. We have good imaging. You treated all early stage lesions. I remember Patrick Walsh was a visiting professor, and we had a patient with a Gleason 3-3 T1A disease. He said, perfect candidate for surgery. And we treated with one form of therapy. So it was hormonal therapy, radiation, or surgery. That's what we had available to us. I wrote an editorial back many years ago, and it was early stage prostate cancer. Do we have a problem with over-detection, over-treatment, or both? And I said that urology will be judged the way they treat prostate cancer. And I think we were judged, and that was the guidelines for early detection took into account that we were over-treating a lot of patients. We were an early adopter of surveillance at UCSF. So we had no change in the volume of surgery that we did because people came to us to get an assessment for surveillance, and they stayed with us. The more recent past is we screen all and we biopsy some. So I thought the antidote to over-treatment was to active surveillance. And now I think you should try just not to even identify these low volume diseases. Active surveillance is generally limited to low risk disease. I think there's an increasing interest in expanding that, and I'll show you some data on that. And there's a big interest in focal therapy. I know that you're doing here risk reduction, and I'll quickly review that as well. So I'm going to show you quickly here what to expect with active surveillance. We have about 3,000 men on active surveillance. We have a large cohort of men, and I'll show you the data on this. Our series at UCSF is about 80% low risk, about 20% intermediate risk disease. So we have a little higher risk population than most active surveillance series. So a good rule of thumb is if you take people with grade group 1 or low volume grade group 2 disease, put them on surveillance, which you can tell patients is at about 5 years, the progression rate's around 30%, by 10 years, 50%. So about 50% of patients at 10 years will be treated. Higher for grade group 2, lower for grade group 1. If you look at major upgrade-free survival, it's much different. So most patients who progress on surveillance do so marginally. They go from a 3-3 to a 3-4. And actually, low volume 3-4 is a low-risk cancer. So most progression is rather mild to moderate. If you look at the treatment-free survival, again, at 7 to 10 years, it's around 50%. So about 50% of men get treated at 10 years. If you look at the risk of metastases at 10 to 15 years is around 1%. So it happens, but it's very uncommon, and generally not for grade group 1 disease, for higher volume grade group 2. Now, and Isaac may remember this, I think it was about 2 years ago, NCCN started to change their guidelines about higher volume grade group 1 disease, about those patients should be treated. So we looked at this. So first of all, low risk disease is generally a low volume cancer. About 80 to 85% of patients patients with low risk, about 15% have higher volume disease, so multiple cores positive. So we looked at this, and Kevin Shee, who's a remarkable R5 at UCSF, did this with me, and it turns out that volume does predict for progression, but no difference in outcome after surgery. So that means a patient who's got high volume grade group 1 is still a good patient for surveillance. They may need more careful surveillance, but there's no, if they progress, there's no difference in outcome after surgery compared to men with a lower risk disease. Does delay in surgery for grade group 2 affect outcomes? So again, in urology, we've been held hostage by Gleason grade for too long. So we have this cliff we have that if you have grade group 1, you have low risk disease. If you have grade group 2, it's called clinically significant. It's like falling off a cliff. But again, a lot of these are very low volume grade group, and I'll show you how you can actually differentiate these grade group 2s from one another. So we've looked at this multiple times. And what we did here is we looked at patients who had upgrading, had immediate surgery, patients who had upgrading, had surgery within 12 months, and had another group who had surgery beyond 2 years. And it turns out that the patients who had immediate versus 12 months had no difference, but those who had treatment at around 2 years or more, it didn't get, the p-value is 0.06. So it's telling us that, in fact, waiting a long period of time may put them at somewhat of increased risk for recurrence after surgery. So I'm going to show you the most updated data. This is being submitted now. So these are people who've been followed for 10 years or more for grade group 1 disease. So what's the natural history going forward? And again, a good follow-up on these. And this is the data here. So despite guidelines that surveillance is the preferred form of treatment for low-risk disease, it's still variably treated across this country. So we have this large data set. So at UCSF, what I did many years ago is I had all my patients consent for research. This is for a long period, whether it was prostate, bladder, or kidney. So they all consented for research. We have well-annotated tissue, so we can follow them over time, do research over time. So we have this big data set repository. And we looked at several things here. We looked at any upgrade, major upgrade, or change in volume, or change in volume and grade. So it turns out that in 10 years, the overall any upgrade was rather high. So if you go 10 plus years, around 67%, but the major upgrade rate was around 17%. So about 17% of patients beyond 10 years, if you look at it, will have major upgrade. A major upgrade would be like going to a grade group 3 disease or higher. So most changes are rather limited, and in volume or grade, about 17% will have higher grade disease. I'm going to come back at these numbers when we talk about this issue of renaming grade group 1 disease. Active treatment, so most patients by 10 to 15 years on surveillance will get treated. And if you look at grade group 2 volume, so here I'm just showing you the major upgrade rates. And so again, just grade group 2 disease alone doesn't do it, but if you start to get grade group 3 disease, higher volume, higher risk. So a lot of heterogeneity outcomes in grade group 1 patients if you follow them a long period of time. Can we stop at some point? The background of this is a group it's actually led from Chicago. That's Howard Rolinski. Some of you may know him. He has a large group of men on surveillance. He's got a podcast and everything on this. And he asked a question to many of us. He's a patient, 76-year-old man, grade group 1 disease, Gleason 6, less than 1 millimeters, diagnosed in 2010. He was advised by a very prominent surgeon to have his prostate out. And he didn't. And he had multiple negative biopsies. So he asked the question, well, do I need to follow anymore? Is there a time if you're free of any progression by 5 years or 10 years, do you need to be followed? And he asked people from around the world about this. I was one of them, and you see a lot of common faces here from around the world. And but the response was rather remarkable. Some said don't do any surveillance at all. Some said keep doing MRIs, PSAs, and so we actually so about 31% says just stop. About 44% said surveillance, genomics, MRI. And actually, we had the data on this. So we looked at this, and I actually gave them acknowledgments in the article, and this has been published. And it turns out that, in fact, even for those patients who go 5, 10, 12 years, there's a small risk of progression. Major progression is not common, but it's still there. So I do think even if you go on 5 years, and I'll show you the things that predict for progression, they still, if they're in good health, and they have a 10-year life expectancy, you still follow them, but you don't need to follow them as religiously as you did early on. This is a table of what predicts for upgrade. So we've looked at it, and I have all the articles behind this. Now, one thing, I was at Johns Hopkins many years ago, and Michael Liebman was a fellow, and Bill Catalona asked a question of Val Carter, what about age? And the Hopkins cohort had an older age population, but we actually had a younger age population. And I see many young men who've been diagnosed with low-risk disease, haven't completed their families, and they're advised for immediate treatment. And now with a whole body MRI, I'm seeing a lot of very young people getting whole body MRIs, Galleri tests, looking for cancer. And I've seen these men get an MRI, normal PSA, abnormal MRI in the prostate, get biopsied, find low-risk disease. So, and it's very common that you'll see patients say, well, if you're young, you should be treated. If you're a young patient, you should be treated. So Michael Liebman does the article. He sets a standard for this in JCO. It turns out that young age is favorable. So older age patients have a higher risk or higher rate of upgrading compared to young patients. So younger patients, even if you control for Gleason score, PSA, T-stage, younger patients have more favorable patients. So young patients are still very good candidates for surveillance. And again, a lot of them have not completed their families. I've had a lot of letters from patients who've shown me pictures of their kids that they had on surveillance. PSA density, PSA density, it's a simple thing. PSA divided by volume. Every analysis that we do shows PSA density to be very strongly predictive. So PSA density over 0.15 predicts for progression. The lower, the better. 0.1, less risk compared to 0.1 to 0.5. Genomics predicts, our most recent, and I showed you the data on the 10 to 15-year outcomes. The genomics comes very close to being statistically significant, more significant than actually MRI. PIRADS 4 or 5, more than normal PIRAD score. Grade group 1, again, volume of grade group 1. For grade group 2 disease, it's volume the device that moves the progression rates higher. It's not just having grade group 2, it's actually grade group 2 volume predicts for progression. Obviously, if you had a negative biopsy, your risk is lowered. And as I mentioned, grade group 1 volume. New biomarkers, there are many, but I think the most important one that needs to be implemented right away, and I think your pathologists are here, probably doing this here, is this Gleason pattern 4 histologic subtypes. These need to be reported in the pathology reports. And unfavorable histology is generally intraductal, or we call large cribriform histology. These need to be reported in your pathology reports routinely because they predict for outcomes. So we were part of a large study, the Canary study here, where all of us who did prostatectomy built this microarray and looked at this. And unfavorable histology predicts for progression or outcome after surgery. And actually, the histology correlates with genomics 80% of the time. So this is a very easy thing to get, and your pathologists need to be reporting this routinely. And it actually, the unfavorable histology drives the outcome in grade group 3 disease. That's what drives it, this unfavorable histology. And our data from UCSF looks exactly the same. The other thing is, can we do better at lower cost, make it more available? Big interest in AI. AI is everywhere. And because I have this large data set, we have this well-annotated tissue, we're exploring the use of AI in pathology. A medical student today, I would be very cautious going to the fields of pathology or radiology. They're going to be changed with AI. We will still need these alpha, radiologists or pathologists, but I'm not sure we're going to need as many pathologists or radiologists going forward. So since I had the data, so what we had here is you need to have patient consent, which we had, well-annotated tissue, and known outcome. So I actually know how patients did, biochemical free survival, metastases, prostate cancer-specific survival. So I know that on my patients. And I have 2 scanners that we purchased. So we're actually actively doing this. Remember, around the world, you make a diagnosis of cancer really with a biopsy. That's how you do it currently. It's going to change with time, but that's how you do it currently. And you can upload those images anywhere in the world. And you can get centralized expertise reading. It's non-destructive. You don't have to generate RNA and DNA. And it's lower cost and obviate the need for additional tests. So this is like our Terra AI. This works. So we actually submitted 2 abstracts, one to ASCO GU and one to ASCO Now. And we looked at patients, the recurrence rates after surgery. We use their AI algorithm, and it predicts for biochemical recurrence, metastases, and survival. So it actually works. We think we could make better, and we're looking at other. We own the images. This is governed on an MTA. We're looking at other companies to look at this, and we may do an in-house AI program with Berkeley. But it works very well. I think this is going to be something important. So, right now for surveillance, you want to decrease the burden of surveillance with time. You want to reduce the number of positive biopsies. And now we know all those factors that predict progression. So again, if you have a high volume grade group 2 disease, high genomics, high risk 5, cribiform, volume, these patients need to be followed. These are the patients you want to do early confirmatory biopsies on. And you do need an MRI. So you need an MRI guided biopsy. I still see patients who get their biopsies without an MRI. We argue with some referring physicians about getting an MRI, and you need to do that. So the high-risk patients get kind of an early confirmatory biopsy. Those obviously in poor health, you do watchful waiting. But with low PSA density, favorable genomics, favorable MRI, these people don't need many biopsies. We'll get a biopsy by 18 to 24 months, again, if they've had a good MR-detected biopsy. So they get less intense screening. We're actually determining now that I showed you there's about 1/3 of patients who never progress. So now we're trying to determine who they are, because if you identify them, you may just say you're done. No MRIs, no more biopsies. So focal therapy. So focal therapy is taking the world by storm. So I think internationally, there's a lot of people doing focal therapy. And of course, as the market expands, payers get into this, there'll be even more of this. And I know you're doing it here. And for low-risk patients, is there a role for this? I think the rationale is we have much better localization techniques. It's very limited morbidity. I'm sure here and elsewhere, no matter what energy source you do, the risk of erectile dysfunction, bladder or bowel complications is very, very low. The thought, of course, now is this whole issue. In fact, many people getting focal therapy today have actually low-risk cancers. They define them by grade group 2 disease. It's usually lower volume. These are not high-risk patients. So a lot of these patients don't need anything at all, but it's still being focally. But for the men on surveillance, this issue of risk reduction. Now, the concerns, of course, is overtreatment. We have very good short-term outcomes, 3 to 5 years. We don't have good 10 to 15 years in large numbers of patients. Does it make secondary treatment, if needed, more morbid? Well, I think there are 2 groups of patients for this. One is, and I do think PSMA PET, the use of PSMA PET in addition to MRI better localizes the cancer. So I try and get PSMA PETs. I don't do focal therapy, but I have people that do. And I'm running a large trial in intermediate-risk disease on PET, and I think that's going to be, we're going to see PET move to lower-risk patients. So again, if you have the well-localized unifocal intermediate-risk patient, that's a good candidate for it. But what we're starting to see now is a patient who's got a dominant tumor on one side and a microfocus on the other. And the idea there, if you look at men who have a dominant tumor and a microfocus on the other side, 80+% of the time, the change in grade or volume is in the target. So the target really is the site of progression. So the thought is that you'll treat the dominant tumor with focal therapy and watch the other side. So it'll be a variation on surveillance. And we're doing both of these. Our infield recurrence rates are about 40%. So we have a little higher risk group. I don't know what they are here, but infield recurrence rates around 40%. Now we're doing double tap. I don't know what you're doing here, but double tap is like doing HIFU twice. Big interest, big Twitter. A lot of people spend time still on Twitter, but on this issue, is it time to rename grade group 1 disease? That is okay. Let's try and get the word of cancer out of it. And Matt Cooperberg at UCSF is a strong proponent of this. I am not, but I'll show you why I say that. So 4, it decreases over treatment. So it eliminates stress and anxiety, maybe. It eliminates being denied overcharged for life insurance. I've seen that very rarely. And I go at it with insurance companies on this. But the concern is it's cancer. So it has the hallmarks of cancer. Clearly has the pathological hallmarks of cancer. Would patients not comply with surveillance? Could it be confusing for patients and physicians? Would insurers not reimburse for imaging or testing? My big problem with this is you're dichotomizing prostate cancer. So you're saying, okay, we have one group that we're not going to call cancer, but a group very similarly we're going to call cancer. And this is some of the data from this. What I'm showing you here are 2 things. One here is the patients who on so these are their CAPRA scores. So we use a multivariable risk model called UCSF CAPRA, been validated around the world in tens of thousands of patients. Simple to do. You don't need a calculator. But 0 through 10, these are low-risk patients. And I'm showing you here, and these are patients I've operated on called CAP. Once they get surgery, we have another score called CAPRS, which takes into account T-stage and margin status. And here in blue here are the patients who have grade group 1 disease. So down here on these biopsies, you can see that these are both low risk patients, CAPRA 0 through 2, low risk, but you'll call one cancer and one non-cancer. It makes no sense to me. It's really a spectrum of disease. These are a surgical series, and I'll show you later how our surgical series has evolved over the last 20 years. So I think this is a teachable moment. And now we're doing whole body MRI. You know, I was on the FDA panel for a multi-cancer detection test, you know, the Diller test. We're going to have a wave of early detection for cancer. But I think we need a modern operational definition of cancer, 21st century definition of cancer. Again, it's a growing issue with cancer in developing worlds, and newer diagnostic tests, as I mentioned, will make this more of an issue. So I think patients need to understand whether it's a breast cancer or prostate cancer, thyroid, we're picking up all these indolent cancers. We need to let them know that this is really a spectrum of disease. And just like we did with infectious disease and heart disease, we learned to understand the risk and treat them appropriately. So I think it's still a cancer. And as I showed you, about 17% actually progress significantly over 10 years' time. I'm showing you here is good work by Sam Washington, colleague of mine at UCSF. This is the variability of surveillance around the country. So even though everyone says we should be doing surveillance, it's quite variable. The highest rates are here in the San Francisco Bay Area. I was pleased to see that. But you see these variable rates all around the country. About 20 to 30% of the treatment decisions are unrelated to the patient or to their disease status. So that means there's a lot of variation that's unrelated to any pathologic clinical reasons. Where does surgery fit in? So I'm going to go from surveillance to surgery because I think surgery is not being using enough, and I'll show you where. So I've done thousands of cases open and robotic. I keep track of all of them, and I do think robotic's better. If you actually compare them both, the outcomes are good both ways. So there's a small difference in hospital stay, transfusion rates, continence rates are really the same. I think potency rates are better with robotic. So I've done thousands of both of these. I think the best people to test new technology are those who use old technology. So a lot of surgeons in my area never went to robotics, but I felt, gee, I've been down there thousands of times. And I think I've been here before. And I think the learning curve for an experienced surgeon is steep, which is good. That means they adopt new technology more quickly. Those that are willing to do it. So what I'm showing you here is that we developed a large data set many years ago called a Capture. So this is a data set, 40 sites around the country where we tracked outcomes of men, we call ambidirectional data set. So patients who previously treated and newly treated, and we tracked their outcomes over time, over many years. And we looked at this issue of cause-specific cancer mortality. So we followed them over time, and what we found at 10 years, and we found at 18, 20 years with the patients these are CAPRA scores here, low risk to high risk, and you're looking at prostate cancer-specific mortality from surgery, various forms of radiation, hormonal therapy. Now, most patients in the U.S. are treated or sitting down here, these CAPRA scores between 0 through 4. But consistently, we found that men with high-risk disease had a lower risk of dying of prostate cancer compared to men treated with radiation surgery with or without hormonal therapy. And we controlled for everything: insurance, age, we control for all variables. Now, a lot of people say, well, you missed a covariate. But if we missed a covariate, that covariate would have to be something more than 20 points to a Catan score. So there's something here which I think is important. And other data sets have shown the same thing. So the benefit to surgery may be in high-risk patients. And we learned this over time. So this is UCSF over the last 20 years. And here are the low-risk patients 20 years ago, intermediate risk, high-risk patients here. And we've gone from the majority of our patients with low-risk disease being undergoing surgery to the minority now. So UCSF, the number of people with low-risk disease undergoing surgery is about 6%. Generally, these are high genomic scores, mutation carriers, but it's rare you'll see a grade group 1 operated on at UCSF. That's much different. I wish everyone showed their data on this, but we've gone to operating on low-risk patients to now operating on high-risk patients. The one thing I see consistently, the limitations is this whole issue of, what are the risk group outcomes? And a lot of people use NCCN or AUA. They really do not work. You're lumping people in these large categories, and they can get in those categories by many different ways. The very low-risk disease is no longer relevant. We've shown this over time. That's kind of gone away. But intermediate risk disease is really a spectrum of disease. I don't think you should use NCCN or AUA. I think you need to use a multivariable model. And again, the one we chose is CAPRA, performs much better. So you can put patients into categories much better. You can find this online. And again, it's been validated around the world. It's simple to calculate, but it's a much better system. Well, it doesn't cure all men. Okay, so this is the biochemical or secondary treatment-free survival of my patients. I'm showing you here, detectable PSA. We also say they fail if they're treated. Now remember, the cut point for recurrence is generally thought to be 0.2, but with hypersensitive testing, there's a lot of people who may get treated before they reach the cut point. So at UCSF, we say you failed if you had detectable PSA or you got secondary treatment. So it's a very high bar, and it varies over time. The metastasis-free survival is actually quite good. So they may recur, but the risk of metastasis is quite low, and prostate cancer-specific survival is quite good. I just looked this up because I had to give a talk at Oxford, and if you look at recurrence and metastases, I want to point out that positive margins may predict for recurrence, but they do not predict for metastases. What predicts for metastases are things like seminal vesicle invasion and extracapsular extension. It's not positive margins. So if you have an undetectable PSA, we're doing a lot of work in this area about who needs adjuvant therapy. Lymphadenectomy. So, if you look at guidelines, they recommend doing lymphadenectomy with a rather low bar. So and if you look at all the groups, they say to do probability of 5 to 7% extended high risk of nodal involvement, probability of 2 to 7%. The highest rate of positive lymph nodes in all surgical series is 20%. So you're going to do a lot of lymph nodes, and they're going to be negative. And they talk about extended lymphadenectomy. So I see this all the time. And in the capture data set, the average number of lymph nodes removed, both sides, was 6. So a lot of extended node dissections are not extended node dissections. And we have shown at UCSF, using a lot of our PSMA PET data, that about 30% of pelvic recurrences are outside the template for either surgery or radiation therapy. That means you miss them. They're not there. We've looked at this. Again, I keep outcomes, and this is in the literature. We cannot demonstrate a clear therapeutic benefit. So there's no level 1 evidence to show a benefit. And at UCSF, there was no relationship between the extent of the lymph node dissection and outcome. Now, of course, the more nodes we got, these probably higher risk patients, but the more nodes we removed, actually the recurrence rates were higher. It is true, though, even for patients with positive lymph nodes, the all-cause and prostate cancer specific mortality at 5 to 7 years was good. Now, this is my data for, if you said, okay, Peter, the patient with positive lymph nodes, how many did you cure? So what's the recurrence rate out at 5 to 7 years? So I do admit that about 18% of patients, positive lymph nodes treated UCSF, no adjuvant therapy, but the PSAs are 0. So there is a cohort that you might cure with surgery. The problem with surgery is extended lymph node dissections are the ones that have the highest risk of side effects. So right now for us, it's those extended lymph node dissections. If you look at lymphoceles and other things, and this was not my. I happened to, one of my colleagues was out of town, and I had to see one of his patients, and this is a cystogram showing this bladder, which has got 2 big lymphoceles next to it. So it's associated with increased morbidity, and it's usually lymphoceles. So for radical prostatectomy, so I do lymph node dissections very cautiously now. So all my patients get a PSMA PET ahead of time. They tend to be high-risk patients. PSMA positive, we still offer them surgery. PSMA PET negative, very high risk. I'll still do it. Let's see what happens here. But I think with surgery, the issue is, can we do it better? And to me, the future of cancer surgery is image guidance. Now, whether it's going to be radionuclide guidance, is it going to be PSMA fluorophore guidance, high-powered microscopy? I think it's going to be something. So again, knowledge that low-risk patients are candidates for surveillance, higher-risk patients may benefit from surgery. Novel imaging and biomarkers are changing the field of prostate cancer. And this is a patient referred to me. You can see this that lesion there. He was a big prostate. He's from Mexico. Came to me through I think Seattle, and that cancer had been missed. So that cancer that you see there, the T3A tumor, had been missed. So I think the issue with surgery, of course, is again. We're applying to high-risk patients, and then we know that in men with high-risk prostate cancer undergoing surgery, 15 to 40% will have positive margins, and we may miss metastatic disease. So we know we have this bar that we're facing with these high-risk patients who we think benefit most. Can we do better? So again, I think better imaging is going to be critical here. And I'll show you what we're testing at UCSF, and it's intraoperative PSMA fluorescence. That means these are patients. So I'll show you the data for the phase 1 study. I'll show you the design for the phase 2. We've actually finished it. I'm waiting for the results. But this is a PSMA fluorophore. So what these patients do is they get injected the day before. We looked at the time of injection. You could actually do it the same day, but it's kind of, I do a couple a day. So for us, it actually works well, especially because my patients come in from out of town. They get the day before, and then they undergo surgery, and then you have the advanced Firefly camera on, you turn that on, and you light up the tumor. The only side effect is green urine. So from the PSMA fluorophore. And this is just one of my cases here. I'm showing the tumor lighting up there, and you see it right there as you light it up. And it's very cool. And here's a patient of mine that I wouldn't have seen this. I see just a little tissue down there. I go ahead and remove it, and you see that bright spot. That's a disease left behind at the apex. And we remove that. That's positive. This is a patient undergoing lymphadenectomy. Now, this was positive on PSMA ahead of time, but this is the intraoperative PSMA fluorophore lighting up that tumor in the lymph node. A residual disease was identified in about 8% of these patients. And this is, again, another tumor lighting up. This node was deep. You would have seen this, I think, under usual lymphadenectomy. It was deep between the bifurcation of the vein right up against the nerve bundle down low. I mean, it's really a deep spot. We knew it was there. We could see it, but it took a little effort. And again, this is just a pathology cross mount showing that, in fact, the pathology and the imaging correlated very, very well. Again, what we found was adverse events, discoloration of urine in 22 or 24. There were no grade 2 or higher adverse events. This 25 micrograms per kilogram dose we came to avoid the background fluorescence. So this was the dose that looks to be best. Safe, well tolerated. The you know, it was a small study, but the reviewers asked us to look at negative, positive predictive values. We gave them to them, but against a small study, so I'm not sure how good they'll be going forward. So we did a phase 2 study. These studies are not easy to do because you need to really be careful as you do these. So again, this is a phase 2 study, UCSF, Hopkins, Memorial, and Mayo Clinic. We were the largest accruer to this study. And the primary endpoint here, again, these are all high-risk patients, CAPRA-6. So if you're going to do studies like this, you need to do them on high-risk patients because you need the number of events to be able to test the hypothesis. And what you did is, of course, it was a randomized study. So everyone got the fluorophore. Half the surgeons were able to turn the Firefly on, half were not. And the primary endpoint was margins. The FDA wanted margin rates. And of course, if you saw disease, you could do an initial biopsy for cause, either under white light or under fluorescence. For cause means you saw something by either form of imaging, and you needed to take that tissue and get a frozen section on it. Positive, you took another margin. So the idea here was you convert a positive margin to a negative margin. We had other secondary endpoints, but that was the primary endpoint the FDA wanted. Positive margins do it doesn't, as I showed you, it doesn't predict metastases, but it does predict second treatment rates, which can be morbid. I'll get into that in just a second. So positive margins, don't ignore them. Again, and we've actually looked at volume and number. So microfocus is different than 10 millimeter margin. So again, the primary endpoint were positive surgical margins, and then the endpoints were greater than 1 positive surgical margin on final histologic assessment and number. But we looked at a lot of secondary endpoints. So this is patient in mind. This kind of floored me. I think to me, I'm looking down at the apex of the prostate. Now that looks like a pretty good margin to me. I mean, when I look at that, I don't know what you feel about that, but that to me, it looks like I've got tissue at the apex. It's not too tight. It looks pretty good to me. And see this plays here. So the lights up right at the apex. I mean, it kind of floored me when I saw it. And it says bright. So I go back down and I take that tissue, and that was positive. I wouldn't look. I've done a lot of surgery. I would have missed that. I would not have seen it. It's right down there at the posterior urethral plate, and that's positive. That was positive on initial, negative on the additional section. The secondary endpoints here are margins at 6, 9, and 12 months. The challenges to these trials are, one, you have to adhere to standard surgical protocol at all the sites. So again, these are, you got to be committed to these studies. You got to do the margins, frozen sections. You want to standardize pathology reports. You want to be sure the pathologist understands what you're doing. So generally, we've had these with our other sites. We've met with both the surgeon and the pathologist to kind of go over because what you're doing is you're taping all these procedures. So you have the tapes to look at. And then you look at the biopsies. And you got to do this timely. That means don't wait to the end of 3 months to do you want to do this every couple of weeks. You want to do these studies correctly. Quick note on biochemical recurrence. So I've tracked biochemical recurrence over time, and I don't know what you do here, but if you look at NCCN, there's this issue about do you do adjuvant therapy or do you treat it biochemical? And there's a tendency for biochemical recurrence for radiation therapists to give radiation right away. So I've looked at patients who've had persistence of detectable PSA versus those who had undetectable PSA and then a detectable PSA. So these are totally different patients. If you have a patient who's got a persistent PSA, so you did surgery, the PSA is positive, this is a much different cohort. 80+% of these patients get treated, different than those who get undetectable become detectable. So about half of those patients at UCSF, we can never find anything. So we watch them. So, and actually I just got a call from a patient who I was saying this at dinner last night, a patient from Philadelphia who was treated at Memorial, sees, you may be next, he's seen everyone. He's gone to Hopkins, he's Penn, and he's surgery at Memorial, 2 years out, favorable pathology, at least in 3, 4, favorable decipher, negative margins, PSAs detectable, The PSA doubling time is about 13, 14 months. It's low. He wants to know what to do. He saw this article and he reached me. He wants data. I told him these are observational data, so you can't make clinical decisions based on this, but we'll run some numbers for you. First off, at UCSF, so is there any radiation oncologists in the room? So I don't want to look. Radiation oncologists are my friend. We send 20 to 25% of the patients at UCSF who get radiation come from urology. So I don't think there's any department of radiation therapy in the world that gets as much support as we give them. But there's this thought that you need to give radiation therapy below a cut point of 0.2. So I don't know if this is said over and over again. It's based on historical data. There's no relationship between PSA and radiation sensitivity. So there's no biological rationale for that. But it just turns out that men who have a higher PSA have a higher risk disease. So with PSMA PET now, we know that the sensitivity of PET improves as the PSA goes up. And again, at UCSF, for PSMA-directed therapy, we will change the field size or the dose 30 to 40% of the time. So if you knew where the disease was, you change your treatment. And we just simply look, this is new data here, and I'm looking at giving radiation at PSA cut points below 0.15, 0.2, 0.25, or greater than 0.3. No difference. Okay, so that means you don't need to treat right away. You can let that PSA rise a little bit. And I do this especially in people who are margin negative high-risk patients, because the local recurrence rate at UCSF for PSMA, this is for all the patients who either treated UCSF or around our catchment site. You know, we were one of the UCSF and UCLA got FDA approval for PSMA PET. The local recurrence rate is about 22%. And these are people who got PSMA PET and local imaging. So they got MRIs and other things. Most recurrences are actually regional. That said, if you're going to fail after surgery, where do you tend to fail? It's not local, it's actually regional. It's usually in the lymph nodes. The risk of visceral metastases is very low at about 20%. So this tells us that, in fact, you don't need to treat them right away. PSA threshold for salvage therapy was not associated with benefit. This is a case of mine. So this is a patient I operated on who had a radical prostatectomy, T3A, negative margins, N0, and a good node dissection. Post-op PSA was 0.58, repeat 0.6, favorable PSA velocity. He was carrying a CHEK2 mutation. And we did a PSMA PET on him, and he's got this presacral lymph node. Now, this is normal-sized lymph node. These are hard to find during surgery. I've been there. I mean, if there's a normal-sized lymph node, you could miss this in this area. And I wanted to get the fluorophore under compassionate use to do this surgery, but I couldn't get it. So he flew to Germany where they did open radio-guided surgery. This was positive, and he is out now 5 years with an undetectable PSA. So no local therapy, salvage surgery, PSA less than 0.015 at 5 years. These are two patients of mine, again, high-risk patients who had detectable PSAs. Again, the risk of local recurrence was low. And on one here, we see positive lymph nodes, one a bone metastases. And I just have another patient I just saw now that they have bone metastases and a lung met that in fact, these people have systemic therapy of regional disease. I don't think they need radiation locally. They may need it regionally, and they need hormonal therapy. So I think waiting a little bit to identify the disease allows you to tailor the treatment for better outcomes. Radiation, the prostate bed carries significant morbidity. If you follow these, this is SEER data, but I can show you UCSF data showing that if you look out at 10 to 18 years, the risk of radiation-induced toxicity of the bladder, we put fiducial markers in, we tell them to keep their bladders full. Even when you do that, this is not insignificant. I can't tell you the number of times we've been taking care of patients in the middle of the night who have bad bleeding. So the morbidity needs to be put in place. So you want to give it to people who benefit, but not to those that do not. Now, at UCSF, we actually looked at this recently. We looked at PSMA-directed therapy versus standard imaging. We see no difference in outcome at a mean follow-up of 46 months. But this is evolving so we've changed our treatment approach. This is evolving. I think with more follow-up, we'll see a benefit to PSA testing. And this is the data from Germany showing that PSMA-based treatment had a better outcome than those who had standard imaging. So I think PSMA, if you can find where the disease is, you can treat it better. So in summary, prostate cancer is a spectrum of disease, should be treated as such. Risk assessment should be refined and nuanced. Again, use a multivariable model. I think treatment decisions should be based on cancer characteristics, patient age and health, and importantly, personal preferences. I told a reporter one time, look, I am very comfortable with the decisions men make about their disease as long as they have the best information currently available. And too often they do not. Too often they just don't have good information. Outcomes should be tracked. I think we should all be looking at our outcomes. We learn from them, we adjust them. We can be very transparent to patients. If a patient comes to me and says, you know, what's my risk of dying of prostate cancer 10 or 15 years? What's my risk of this or that? I have that data. And I think treatment decisions should be refined with new information. I think we'll continue to innovate, change the way we practice, and we should be open to that. You know, I always say that if we find a cure for prostate cancer, I'll do something else. I'll go back to doing bladder cancer. Thank you very much. I would show you the list of people involved in this, but it's too long. I mean, it's a big group of you. I'm very blessed at UCSF to have a great group of people in the department, outside the department, working with me. This is much of them. This is more them than me. And people like Michael, Johnny Chang, and Adam Hittleman. So it's a great pleasure and honor to be here. We take your residents, your medical students are doing great at UCSF. So if you got to send them our way. And it's great to see people who train at UCSF here. Thank you very much.